Welcome everybody to this session of the Yellow webinar. Today we have a very special and nice and cute speaker, Federica Pedica. Federica is the responsible for the histopathology section of the liver group in Milan, which is one of the most active in Italy and Europe. And Federica has the possibility to have to overlook a lot of different samples coming not only from Milan, but also from other series in Europe, in Italy and Europe. In addition, Federica was able to organize every Wednesday at 5:00 p.m. our time, a meeting where we discuss cases, and the discussion is very lively and is very, very informative. So moving from histopathology to a period when everything was PCR, molecular biology, genomic, metabolomic, and proteomic, we thought to take advantage of the great expertise of Federica to go back a little bit to what our eyes are looking at the microscope and then get some diagnosis from it. So, and Federica was so gentle to accept our invitation. And so today we have the great pleasure of having Federica with us. So Federica, please, mic is yours. And we are learning a lot from you. Thank you.
Thank you so much, Professor Tiribelli. It's a pleasure, a great pleasure and honor to be with you this afternoon. And yes, this will be an excursus of my my life in biliary tract cancer, which is not so short, but as I was telling you, I will really thank the people that helped me through this this very long trip, which I hope will continue in this place. So now I will go through it. Okay, is it visible? Can you see the presentation? Okay, okay, so let's go. So I'm really interested in biliary tract cancer since I was a resident, because when I started in Verona to look at the microscope and see so many different aspects of this tumor, I was really asking myself, where does it come from, and why does it happen? So I think biliary tract cancer is one of the most heterogeneous cancer, in particular the intrahepatic cholangiocarcinoma, and is heterogeneous also in terms of etiology, location, and also geographically speaking. Okay, because the risk factors are different comparing different places. So what we know until now is that what comes from the intrahepatic cholangiocarcinoma, what is the intrahepatic cholangiocarcinoma, is different from what comes to the larger bile ducts, and the gallbladder is another history itself. Okay. So starting from the very first paper that were depicting cholangiocarcinoma, at the very beginning, the cholangiocarcinoma was just subdivided between intrahepatic, perihilar, and distal tumor. But the interesting thing was that already it was clear that there were differences between those tumors. So these three categories really correlates with anatomic distribution, but also were correlated to different kind of treatments. So then large studies went through the characterization of these different tumors, and what it was clear little by little was that the perihilar group of this tumor was behaving in different ways, and was another heterogeneous category, because some of them were behaving like the more extrahepatic cholangiocarcinoma, instead others which were the perihilar region but were more intrahepatic were the heterogeneous category that was belonging in part to the intrahepatic, but also in part to the extrahepatic. So we will go through this, because this is the category that at the very beginning we were focusing on. So there were some papers proposing different model of progression of intrahepatic cholangiocarcinoma, and these are still, let's say, true, because there was, now you should see the visible pen. So this was the very intrahepatic peripheral, and this was the more large ducts cholangiocarcinoma, and they were different. Also in terms, at the very beginning from 2007, it was clear that they were different kind of tumors. The peripheral intrahepatic cholangiocarcinoma was generally developing on liver cirrhosis, so on a chronic hepatopathy at least, instead of the larger duct one, which was more associated with biliary neoplastic alteration. And they were looking differently. This was more solid, sheets-like, quartz-like tumors, and the other one was depicting the larger bile ducts. So different premalignant conditions were associated with different tumors. And in fact, perineural invasion, which is much more common of the larger extrahepatic bile ducts, was more common in the hilar type and not in the peripheral type, which usually comes to have perineural invasion when it's a large mass and is already invading the hilum. So this was the proposed progression model. In the hilar type, the lesion was growing in the bile ducts, and then it was invading the wall and then forming a large mass. In the peripheral type, instead, all was starting from the very peripheral biliary tree, at the very beginning, respecting the portal tracts and then invading the portal tracts, the connective tissue, and then the hilum. And another paper, very important, was this one. In fact, it was dividing the perihilar group between the, let's say, mass-forming cholangiocarcinoma, which was an intrahepatic cholangiocarcinoma but invading the hilum, and the very extrahepatic bile duct cancer, which was growing in the biliary tree. So the same location, very close location, but completely different in terms of biology, or at least partially different. Okay, and what was clear that it was that the survival, at least at the mass-forming one, was poorer, probably because it was found at advanced stage compared to the more bile duct, extrahepatic bile duct cancer, which can present itself already with icterus, when jaundice, when it's small, instead of the mass-forming cholangiocarcinoma, which needs to become bigger to show itself. So the morphology was at least partially characterized. There were two different groups, the ductular type and the duct type, that actually in the WHO could be, the ductular type could be the small duct-like cholangiocarcinoma, and the duct type would be the large duct-like cholangiocarcinoma. And then there was the so-called combined ductular and duct type. We will go through this aspect because I believe this is something which will change a little bit, but at least there is these two categories. So we have a ductular type, which look really like the segmental and intralobular bile ducts, and then you have the duct type, which is more extrahepatic-like, almost like a pancreatic ductal adenocarcinoma. And this is not just morphology, it's proteomics, because you can see that the MAC5AC was differently expressed between these two types, because the duct type, the most extrahepatic, was expressing MAC5 instead of the ductular type, which usually was not. And this is important because starting from this, when I was still a resident in Verona, and I had the great pleasure and lucky to work with the Dottoressa Bortesi and Dottoressa Capelli and the group of surgeons there, Professor Guglielmi, Dr. Zenente, and Silvia Paquera. We went through this MAC5 because it was also evaluable in the serum, so it was important as a biological marker. We tried to subdivide our cases and see how MAC5 was distributing. Also because the expression of this marker was important also in terms of prognosis, because those patients with MAC5AC positive cholangiocarcinoma had a worse prognosis compared to the negative. And as you can see, we had a very peripheral intrahepatic cholangiocarcinoma, and in our cases, they were very commonly, almost all of them were negative. The very extrahepatic cholangiocarcinoma were commonly positive, but the perihilar were commonly positive, but there was an heterogeneity between those groups. So the perihilar were including at the time both the category of the mass forming invading the hilum and the extrahepatic invading the parenchyma. And so we also studied S100P because in that period, Professor Martignoni told me, you look at the S100P in the pancreatic duct adenocarcinoma. It is important for progression. Looks like it would be interesting. So we tried to do the same with cholangiocarcinoma because other than, they are cousins, okay? Pancreas and liver are cousins after all. And so, as you can see, the very peripheral cholangiocarcinoma was always negative for S100P. The hilar cholangiocarcinoma was always positive, the extrahepatic for S100P, but the hilar, we subdivided the hilar and the perihilar region between the mass forming invading the hilum and the very extrahepatic bile duct cancer, and we found out that the very extrahepatic, the one so-called Klatskin tumor, was always positive, but the mass forming invading the hilum was sometimes was negative for this S100P. So only the very peripheral cholangiocarcinoma, the one coming from the smaller bile ducts, was negative for S100P. And then some papers came out about this item. And again, the perihilar was found to be positive for this marker instead of the peripheral, which was commonly negative. And this was, again, important for progression and for the aggressive behavior because the extrahepatic, the perihilar was acting like an extrahepatic cholangiocarcinoma. And again, another paper demonstrated that the pancreatic ductal adenocarcinoma has some similarities with the hilar cholangiocarcinoma. So again, all these data point together that the fact that something that is inside the liver is commonly different, is completely different from what happens on the larger bile ducts. And this is important in terms of management and understanding of the disease. So we also went through the look for another marker, which we look at, because another problem for pathologists is that we have no marker, specific marker for biliary differentiation. We found out that, again, MAC5AC is important, S100P is very important, but it cannot differentiate between, for example, a cholangiocarcinoma and pancreatic ductal adenocarcinoma. And also the composition of different markers is not able to identify specifically biliary tract origin. And this is important for pathologists and when we have small biopsies, but also to understand the disease. So we went through this cystic fibrosis transmembrane conductor regulator for athesis, and we decided to work with the paper, and now we are almost ready for submission because we went through cholangiocyte pathobiology, and we found out that this cystic fibrosis transmembrane conductor regulator was interesting in terms of functioning of the cholangiocyte, and it was a protective protein for the cholangiocyte. So we went through the literature for CFTR, and we found out no one had studied this gene and its protein in the neoplastic liver. We found just a few papers on non-neoplastic condition, and we found out that in patients with cystic fibrosis, there was aberrant or no expression at all of the protein. And then in patients with hepatolithiasis, the expression of this protein was decreasing compared to the normal condition. So we went through our cases, some of them. We studied 40 intrahepatic cholangiocarcinoma, subdivided already between small ducts and large duct, because at that time the WHO came out. And then 7 combined hepatocellular and cholangiocarcinoma, which is another category that it's quite common in here, but it really represents what is in the literature as percentage of incidence. We had 8 perihilar adenocarcinoma, 5 HCC, 1 case of biliary adenofibroma, 4 gallbladder adenocarcinoma, 1 case of colorectal liver metastasis, because sometimes liver mets can grow up in the biliary tree and can really mimic an extrahepatic bile duct cancer in terms of radiology, at least. 5 pulmonary adenocarcinoma, just because CFTR was pointing to lung, and then 7 pancreatic ductal adenocarcinoma. And what we found out in normal tissue, it was that CFTR was positive in the lumina and the apical surface of normal bile ducts, in the ductular reaction, negative in the biliary hamartomas, positive in the peribiliary glands, and negative in the normal epithelium. In the very peripheral intrahepatic cholangiocarcinoma, it was the so-called small duct cholangiocarcinoma. It was positive, at least in the great part of our cases. The so-called large duct type intrahepatic cholangiocarcinoma were negative. And this is another example of intrahepatic cholangiocarcinoma with different aspects, with some of this ectatic structure that sometimes recall a biliary adenofibroma underneath, and it was positive in both components. This is another type with, again, looking like a biliary adenofibroma on this site, and which had a part of cholangiocarcinoma associated, and both of them were positive for CFTR. This was a very peculiar third time relapse of an intrahepatic cholangiocarcinoma, which had a neuroendocrine differentiation, and it was still in great part positive for CFTR, so the marker was still present. And this is another intrahepatic, but associated with the intraductal papillary growth pre-invasive component that was positive for CFTR. And again, this was the biliary adenofibroma. So the perihilar adenocarcinoma were completely negative. The metastasis was completely negative. This is the pancreatic normal tissue, the acinar component and the ducts which are positive, and the pancreatic adenocarcinoma, which is negative. The gallbladder adenocarcinoma was negative, and also the pulmonary adenocarcinomas. So we found out that this marker was reliable for intrahepatic cholangiocarcinoma because it was positive, preserved in more than half percent of our small duct type, independently from grade of differentiation. And it was positive in those cases that had associated this adenofibroma-like component. And so this could also be helpful in terms of further subclassification cell of origin. And it could, we will try also in biopsies to see if it could be a good marker, but it looks like it distinguishes intrahepatic cholangiocarcinoma from all the other stuff, and also from the extrahepatic. So the WHO that came out at the point was that intrahepatic cholangiocarcinoma at the very beginning, in the previous one, was considered a large basket, but not further characterized. Then, since some paper on molecular characterization were coming out, in the new WHO classification, cholangiocarcinoma was subdivided between large duct and small duct. The extrahepatic bile duct cancer is still the same between the WHO 2010 and 2019, with all the perineoplastic, pre-invasive condition associated. And this came together with the molecular classification. Everyone that studied cholangiocarcinoma, I think, was waiting for this, because it was a light in the life of our patients. In 2015, this great paper about a Avul exome and transcriptome characterization of Japanese patients came out, and they found out that 30% of of these cases had a potential driver genetic alteration. But another very important issue was that location was really important. Again, highlighting the fact that in the biliary tree, we have different tumors that have the similar name, but they are completely different. So the intrahepatic cholangiocarcinoma was the one with FGFR fusion and EDH1 and IDH2 mutation, which were not present in the extrahepatic, at least not particularly, and which were characterized by other mutation, and for example, regarding also ERB2. So this was a very, very important paper, and from this, new advances had been done. In the meantime, drugs came out, for example, the anti-ADH1 and anti-FGFR2, and also the studies about immunotherapy. So altogether, this information came to us, and we started working with on our cases to make molecular characterization for the purpose of treatment, first of all, but also now we are looking at them to understand molecular and morphology if they can come together. So, for example, it could be nice to remember that EDH1 is much more present in the hepatocytes than the cholangiocytes, because it's in the mitochondria, and maybe this is important in terms of also of cell of origin. And these are for sure the two targets which are important and everyone is looking at for this patient. So now in Milan, thanks to this very, very wonderful group of surgeons that I'm working with, guided by Professor Aldrighetti, which really go through surgery for cholangiocarcinoma in around 25% of their section. I had the opportunity to look at all this from 2014, to go through all the resection specimen. And now, since the 2020, also thanks to our oncologists, because we have Professor Cascino, Casadei Gardini, and Dottoressa Burgio working on biliary tract cancer, we would have been able to go to molecular profiling for therapy, but also to study those cases. And so we found out that at least in these 88 cases that we have seen until now, 12% of patients had IDH1 mutation. Going to molecular, morphomolecular characterization, that is what we are going to now, we found out that it was much more common to have an IDH1 mutation in the small duct type intrahepatic cholangiocarcinoma compared to the large duct type. Two of them were biopsies, so it's not possible really to be sure if it's an extrahepatic, if it's a large duct or small duct, because when the large duct type infiltrates the liver parenchyma, it can be looking like a small duct type, and so it can be really challenging to divide between the two on liver biopsy. And another one was a mixed type. This was very interesting because the mixed small duct, large duct type was of a woman of 37 years old. She had a very large mass with lymph nodes already metastatic, but she had also a microsatellite instability, and she had a PMS2 loss, and she was found to have a Lynch syndrome. So again, also, although it is very rare, microsatellite instability have to be searched for in the cholangiocarcinoma patients. Concerning the mutation of ADH1, most of them were the one more discussed in the literature, so the R132C. And this was the case of this woman that I was telling you. She had this very small duct type cholangiocarcinoma, which was the major component of this large mass. But since it was a large mass, it was invading the hilum, and in the hilum, it was producing mucin and behaving like an extrahepatic, invading the nerves. And she had also a rhabdoid differentiation that was the component giving metastatization to the lymph nodes. and which was the one that was, and we decided to evaluate for molecular characterization both the rhabdoid component and the other part all together to be sure that we were not missing the most aggressive part, looking for mutation. This is another case, the one with the R100Q mutation of the H1, and this was a patient with a biliary adenofibroma-like lesion associated with the intrahepatic cholangiocarcinoma. And if you go through the cases and they are well sampled, you will find this kind of pre-invasive lesion quite commonly. I mean, it's not so much described, it is described in the literature in case reports, just case reports. But I believe that if we review all the cases that we have in our routine, we will find much more. And this is what we are looking at the moment also. Concerning FGFR2 alteration, they were not, at least until now, different in terms of small duct type or large duct type, because the distribution was the same between the two, and we had also a case of gallbladder cancer, which had also amplification of the RB2. And this is a small duct type, again, with the, which had IFGFR2 fusion. It was, again, with the biliary adenofibroma-like lesion underneath, and also another part of the tumor was looking like a bile duct adenoma. And in the invasive component, it looked like all these structures were filled with aneoplastic proliferation, as it happens in the ducts of and the lobular cancer of the breast. So concerning microsatellite instability, we, again, this does not correlate with, at least at the very beginning of our review, it does not correlate with morphology or with location, but it's important because we had patients with a very different prognosis once that we found out they had microsatellite instability, and this is the only way to provide for the opportunity to have immunotherapy for this patient. And in both cases, in all these cases, it was MLH1 to be lost. This is another category which is very important, which is the combined HCC CC. It has changed from WHO 2010 and 2019. It has been simplified, let's say, from the previous edition because it was subdivided between 4 categories. It was really too much, I feel, for a very heterogeneous and difficult and rare category. But what we found out in this case, for example, it was that this patient had a third promoter mutation that looks really like an HCC, but also an amplification of FB2. So this category needs to be really subcategorized, and different paper came out about the different profile, molecular profile of combined HCC and CC. But for sure, what is clear is that cholangiocarcinoma is an intrahepatic cholangiocarcinoma, and it's not a stem cell or a combined anymore, but it's just a peripheral cholangiocarcinoma instead of these cases in which you have an intermediate cell, like between hepatocytes and cholangiocytes, or in which you have a part that looks really like a poorly differentiated, in this case, hepatocellular carcinoma with alpha-fetoprotein positive, and another one with glands like a cholangiocarcinoma. So it's a very heterogeneous category, and we have 10% of our cholangiocarcinoma are combined. This is a very important paper about extrahepatic bile duct cancer. As I told you, it's the targets in this subcategory are quite rare. So it's the very, let's say, the main character now for targeting is intrahepatic cholangiocarcinoma. The extrahepatic is poor, like the pancreatic duct adenocarcinoma. And also in these terms, they look like they're similar one to each other. For sure, let's say in our countries, it's much more common to have the proliferation subtypes with papillary, with the precursors lesion. And the mesenchymal one with a very desmoplastic stroma is probably the much more common instead of the immune, which is very rare for us. And this was a very wonderful paper of Daniela C. about this category. So trying to put together all this information, this was just, let's say, different ways to go to intrahepatic cholangiocarcinoma. So making us a map, we could say that we can have a biliary adenofibroma lesion, or a bile duct adenoma, or an hamartoma, or a cyst, like the biliary, the mucinous cystic lesion in the liver, which are neoplastic, in which a biliary intraepithelial neoplasia grows, and then you get to the intrahepatic cholangiocarcinoma. Another lesion, which is very rare, but is the same of the pancreas and does not produce mucus, is the intraductal tubulopapillary neoplasm. We have around 5 cases of this tumor, and these are associated with intrahepatic cholangiocarcinoma. So this is different, at least in terms of morphology, with the intraductal papillary neoplasm of the bile ducts, intestinal type and pancreatic type, which are associated with the large duct type cholangiocarcinoma or the extrahepatic bile duct cancer. So all this information together needs to be put in order, but I believe that morphology together with molecular characterization will help us in putting some points and also better defining therapies. This is another very nice paper that I had the opportunity to go through preparing this presentation about Daniela Cia again. And again, if you think about the mutation, it's really important to find out the most important, let's say, are in intrahepatic. So it means they are different. And this is something that we have to keep in mind. And I believe that this subdivision is just the very beginning, but at least it's something that we are starting to doing in this year. And it's important for our patients, because if we think also about small biopsies or the opportunity to work on liquid biopsies, if you really know very well the disease that you're looking at, you could really use the tissue that you have better, and not to look for the wrong mutation, for example, in the tumors that should not have them, at least. So quite commonly we have to work on small samples. So it is important to target and to look for the right target, and to really use the tissue of our patient in the best way is possible. And this, again, in this paper, really make a good sum up of the situation. And the other thing that we have to think about is that it's really increasing in incidence. We still don't know really very well the risk factor of this tumor, the underlying disease, because it's really common that they have some kind of mild hepatopathy, some kind of NAFLD, not NASH, in the background liver. So we still have to work a lot on etiology too. And this is something that understanding the disease and making good categories, good clear categories, maybe would be easier. And also looking for the cell of origin is not just a matter of, say, just for curiosity, but it's a matter of understanding. I mean, and the two well-known stem cells are the one in the canals of Ehring and the other in the peribiliary gland. But if we go through again the paper and the mouse model that are coming out, it looks like there is the possibility to transdifferentiate between the hepatocyte and the cholangiocyte. And so we really, it is really hard to find this cell of origin, but it can really tells you a lot about the mutation that we are looking at, and making all this correlation needs great effort from I think all the categories from basic researcher to translational to the clinical, to the clinician. So I thank all of you for, first of all, I thank my the head of my lab, which is Professor Doglioni, Verona, because I started there and getting really in love with biliary tract disease. And I really thank my big team in San Raffaele Hospital. And I thank you again, all of you, for your attention.
Thank you very much. Very, very exciting. There is any question for Federica? While the other are thinking, let me ask a question, which may be a sort of difficult question or a stupid question, whatever. I think that the border between hepatocellular carcinoma and cholangiocarcinoma of the small duct is very narrow. I mean, you can go from one side to the other. And I think, if I understand you correctly, the border is not very well defined. The question I have is, how large is the effect of the extracellular matrix in order to take one direction rather than the other? Because this may play a role in, I mean, in guiding the outcome of the disease. Do you have any data on that, on the extracellular matrix?
On the signaling, I found recently again a paper that it was in mouse model. It was not just on extracellular matrix, but it was about the kind of injury that comes to the cell, to the hepatocytes and to the progenitor cells. So if it's, they were telling us, and it's one of the last slide, if it happens that there is an apoptotic signaling, the cell go to the hepatocellular carcinoma. If it's a necroptosis signaling, it comes to the cholangiocyte. Concerning the extracellular matrix, I don't know exactly if there is something, but for sure the macrophage and the cancer-associated fibroblasts are an important cell to go to look at. But cholangiocarcinoma is typically full of these cancer-associated fibroblasts, and I believe that we have plenty of information that are not easy to distinguish. Maybe the single cell analysis could give us some information, but again, we have to use well-defined categories. Otherwise, we have a mixture. And so we should use 10 intrahepatic cholangiocarcinoma small duct and look at the cancer-associated fibroblasts there and what they produce, and then make a comparison with the very extrahepatic, because otherwise, if we put together all these categories, probably we will find contradicting issues. And so I don't know exactly if extracellular matrix has already been well studied, but for sure the tumor microenvironment is something that we have to go through, because the epithelial probably has already told us almost everything that was possible to have. And so we have to put together now information with the tumor microenvironment also.
Thank you. I mean, is there any other question?
Federica,
yes.
Very interesting chat talk. I have a question, because probably I was a little bit confused. You showed the CFTR expression in several cases of cholangio.
Yeah.
Those cases were not from CF patients, right?
No.
Okay.
No, we just tried because we thought, okay, it's a protein that is typical of biliary epithelium. It's not in the hepatocyte. So we were just looking for a marker that could be useful for diagnostic purposes, and that's it. And then we found out those information, and I mean, it was quite nice to find out that it was just in intrahepatic. And so we want to try with biopsies, and the idea is to correlate with MAC and S100. But we are not a transplant center now, so it would be interesting to test it on some explant, for example.
That is interesting because CFTR usually is expressed in well-differentiated cells. It has nothing to do with the degree of differentiation of the tumor?
No. In our cases, no. One of the case was a neuroendocrine differentiation of a cholangiocarcinoma. It was the third relapse, but CFTR was still positive. So I believe it's not a matter of grade, but probably again is a matter of where the cell come from.
Right.
I still believe that, but it's
With Luca Fabris actually published a nice paper about H100-84, which is one of the other H100 that had a strong prognostic correlation as well. And you should collaborate with them because it's pretty much interested in matrix and microenvironment and so on. Yeah,
would be great.
Anyway,
and thank you. It's just a pathology sum up.
You have a question, or Tito?
No, it was actually the same question than Mario.
Thank you.
Exactly the same.
Now, we have Giovanni Sorrentino wants to have a question.
Yes, can you hear me?
Yes.
Yes, so my question is, what's the role of ductal reaction in cholangiocarcinoma development? Can we consider those cells as cell of origin of this tumor? Can we speculate this process leads to cholangiocarcinoma? I mean, there are patients with cholangitis have increased probability to develop cholangiocarcinoma, and in those patients, there are a lot of ductal reaction cells. Can you comment on this?
Could be. It could be. I mean, if you think about the cirrhotic patients, when they develop cholangiocarcinoma, and it's quite common in the HPV subset, it's quite common to find out the cholangiocarcinoma type. So it means that it really looks like it's very, very much resembling the normal bile duct proliferation. So I believe that in the chronic hepatopathy patient, it's much more in which you have ductular proliferation. It's much more common to have a cholangiocarcinoma, and it's something that again, it's one of the points that we will go through. And so you will find a small duct type, much more common than the extrahepatic or something else, because probably those ductular proliferation have other triggers that then translate them in neoplastic cells. And so it's quite interesting also in this sense. So and sometimes in the you will find difficulties in differentiating between normal bile duct proliferation and on a biopsy, because they really looks very, very similar. So I believe it is something that we have to consider in terms of its pathogenesis.
Okay, thank you.
You're welcome.
Any other question? Well, if not, Federica, thank you very much. You gave us a very exciting overview with a lot of good ideas. And keep up with your excellent work, and we'll get together soon. Thank you very much.
Thank you so much.
Bye-bye. Ciao.
Thank you. Thank you. Thank you. Thank you.
Bye. Thank you.
Bye. Thank you.